Okay, well, it's a few minutes past, so we might start. We've got 143 people already, which is fantastic. So I'm going to start by doing an acknowledgement of country. So we acknowledge the Palawa Pakana of Lutruwina, the traditional owners of the land on which we live and work, and also the lands of where you are all joining today. We pay respects to elders past and present as the knowledge holders and sharers, and we honour their strong culture and knowledges as vital to the self-determination, well-being and resilience of their communities. And we stand for a future that profoundly respects and acknowledges Aboriginal perspectives, culture, language and history. So I'd like to welcome you to our webinar today on pain. If you're new to the Tasmanian Parkinson's Project, welcome. My name's Michelle Calisire. I'm a physiotherapist and academic here at the University of Tasmania. I'll pass to you, Jane.
Yeah, welcome everybody. My name's Jane Alty. I'm a neurologist doctor at the Royal Hobart Hospital and an academic researcher in Parkinson's at the University of Tasmania.
And we're really fortunate today to have Associate Professor Natalie Allen joining us. She's a physiotherapist and academic at the University of Sydney, and I'll introduce her in a couple of minutes. So the Tasmanian Parkinson's Project, as I'm sure you're all aware, but if you're new, we do have people join for many reasons. One of them is these educational webinars, and the other is that we run a number of research projects that look at improving the care of people with Parkinson's, as well as the early detection and tracking of people with Parkinson's to design better treatments. So you can see here, we've got 3,750 people from all over Australia joined up. We are aiming for 5,000 people. So please tell your friends, families, everybody you know to join up. You can join up whether you have people whether you have Parkinson's or not. And you can do that by having a look on our website. Even if you just put in Tasmanian Parkinson Project, it'll come up in a Google search. Just a bit of an update. We do have an opening date again for the Parkinson's MOOC, which is our online course about Parkinson's. And that'll be opening again on the 27th of October. And we'll be sending out more information through the Tasmanian Parkinson's Project, so to tell you how you can join. And I'll pass over to Jane just to talk about a couple of research projects.
Thanks, Michelle. So thank you everybody for joining the Tasmanian Parkinson's Project, as well as these educational webinars. We have lots of research opportunities, and we just wanted to give you a quick update on 3 that are actively recruiting now. They're all voluntary, you don't have to do them, but many people really enjoy taking part in research. Michelle, I just wondered if you could click on so we can see all 3 there.
Sure. Yeah.
So the first one is TAS-Test, which is a little computer test that you can do at home. You should have all been sent a link to this, and if you click on the link, it takes you through about an 8-minute little series of tests, as I say, that you can just do on your own laptop at home, and it involves things like tapping your fingers. And really what we're trying to do there is develop a new computer test that can not only help detect Parkinson's more accurately in people that are being diagnosed, but also for those that already have Parkinson's, they can track how they're changing over time and hopefully seeing improvements with things like medications and physio and that sort of thing, but also seeing some changes over the years. So please do take part in that. It just takes 8 minutes. You just need a laptop. It doesn't work on iPads at this stage. So if you've got an iPad, maybe just pass over that one, but laptops or desktops, it works on those computers. The other research opportunity is if you live in Launceston or Northern Tasmania, we'll be inviting you to give a small sample of blood. And what we're interested in here is, are there certain changes in the proteins in blood that can help us detect Parkinson's or different types of Parkinson's? But there will also be the opportunity for some genetic analysis on those blood samples too. So look out for those invites. We are hoping to invite everybody across Tasmania. But for this 4th of September one, it's specifically going to be in Launceston. So we're inviting people with Parkinson's and without Parkinson's, largely from the north of Tasmania. And then the third one, I'll let you say a little bit more about, Michelle, but this is our other third research opportunity. And just to say, you can take part in 1, 2, or 3 of these opportunities. So the choice is yours. Over to you, Michelle.
Thanks so much, Jane. So this one's open to anyone in Australia over the age of 45, whether you have Parkinson's or not. And what we're really interested in is we know that walking and thinking change as we get older, but it's not routinely monitored. And so we're interested in people's perspectives about monitoring walking and thinking over time and how you would like to do it. So what we'll be doing is sending out a small survey and then inviting people to have some interviews. And there is some $150 vouchers up for grabs for this one as well. Okay, fantastic. So we'll move on and I'll introduce you to Associate Professor Natalie Allen from the University of Tasmania. So Natalie's research focuses on exercise interventions aimed at helping people with Parkinson's to live well by optimising movement, reducing falls and managing pain, along with exploring ways to improve health service delivery. She's published over 50 peer-reviewed journals and book chapters, and she regularly presents at national and international conferences, including being invited to present at the International Movement Disorder Society Congress and the World Parkinson's Congress. She's also worked on the World Health Organization as part of an expert panel designing a package of rehabilitation interventions for people with Parkinson's. And today she's going to talk about her work in understanding pain in Parkinson's. And I've just popped up one of her papers there, which I think is fantastic. And I've heard Natalie speak before, and I'm sure you'll really enjoy today's talk. So I shall stop sharing and let you share now, Natalie.
Yeah, thank you so much. Thank you for the introduction, Michelle, and thank you for the invitation also to come and give this presentation today on this really important topic about looking at understanding pain in Parkinson's, because so many people with Parkinson's disease do experience ongoing pain, and I think it's something that needs a lot more attention. So it's great to be able to come and talk to you about it today. So what I'm going to be doing today is talking about pain and what pain is and how it can affect people with Parkinson's, as well as thinking about non-pharmacological ways that people with Parkinson's can manage their pain. So in other words, what we know about how to approach pain management with things like exercise and psychological management as additions to medications. Okay, and as Michelle just showed you, this is a paper that we published last year, so you can see my 2 co-authors there. And if you're interested, you can look this paper up. It's freely available on the internet. And this is just a couple more papers that I'll be referring to today, and these were studies that one of my PhD students, Vanessa, conducted in recent years. So again, if you're interested, then there's a couple more things that you could have a look at. So this is what I'll be covering today. I'll be looking at what pain is and also what chronic pain is. And that'll be broadly thinking about just in the general population, but then we'll look at what we know about pain in people with Parkinson's disease and what we can do about pain experienced by people with Parkinson's disease. So first of all, what is pain? And everyone listening today will have experienced pain firsthand. It's a common human experience. But understanding what pain is and what pain isn't is actually really helpful for people who are experiencing ongoing pain, in that it can actually help you to cope with that pain. So pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So let's take some time to tease this definition out a little. And the first thing to note is that pain is unpleasant. And we all know that, that's not surprising. But that unpleasantness is really important because it drives us to do things to try to get rid of the pain. And this is an important way of the body protecting itself. So the unpleasantness helps us to minimize any harm that might be occurring, or sometimes even to avoid harm altogether. It also changes our behaviour, so you might move differently, which will help the damaged tissues to heal. So pain, although unpleasant, can be a normal and helpful response when our brain thinks our body is being damaged or is in danger of being damaged. Now, pain is not just a physical sensation that we experience. It also has an emotional component, and the size of the physical and emotional components will vary depending on the context or the situation in which the pain is occurring. So if, for example, you were about to go on a big overseas holiday and you sprained your ankle, it's likely to hurt more and be more upsetting than if the same injury had occurred at another time when it was less critical. At the same time, the emotional context can also make injuries hurt less. So, for example, I went skiing with my family a few years ago, and my husband had a really nasty fall onto an icy patch. But it was a beautiful day, he was having a great time, so he picked himself up and carried on. And he said that while it hurt, it really wasn't too bad. And it was only later, after the pain didn't settle down, that he had a scan done on his injury, and he found that he'd put quite a significant tear in one of his glute muscles. And interestingly, once he knew he had actually torn a muscle, he felt a lot more pain and had a much stronger emotional response to it than when he thought he just had a bad bruise. Now, pain occurs whenever the brain decides that we need to have a pain experience to protect us at that point in time. So that can be due to actual tissue damage occurring or due to the threat of tissue damage about to occur. And the brain gets this information from sensors in our tissues. Now, there's actually no such thing as pain sensors, but what we do have is 3 different types of sensors. They're mechanical, temperature, and chemical sensors. And these sensors send messages to the brain, and the brain decides whether the messages indicate there is actual or potential damage occurring. If the brain decides that there is, then the information will be interpreted as painful. So this means sensations are painful if our brain interprets the information that way. Now, the way that pain works best is when we have acute pain. This is when our brain correctly interprets the information from our senses as being a threat, and it's often initially sharp or intense. It can last between a few minutes and a few months and is there to help prevent further damage and to change our behaviour so that the tissues can heal. As part of this complex system as well, the brain will send messages back down the spinal cord that will lessen the amount of information coming from the senses. And we call that descending pain inhibition. And that is part of our brain's response to help us manage when we were injured. So acute pain should disappear when whatever was causing it is resolved. When pain becomes a problem is when it develops into chronic pain. So chronic pain is ongoing pain that lasts beyond the expected time for tissue healing and sometimes can exist even when there was no clear injury or trauma in the first place. It can be there all the time or be intermittent, and it usually interferes with daily life and affects physical and emotional well-being. So the reason for pain becoming chronic or persistent is because there have been what we call neuroplastic changes in the nervous system, so that now the brain is coming to the conclusion that there is a threat and so is producing a pain response, even though there might not actually be a problem. That's not to say that chronic pain isn't real. It is very real and is due to changes in the nervous system. On a simple level, what's happening is the alarm system in the nervous system that tells us when there is a problem becomes very sensitive and easily triggered, and the brain becomes more likely to interpret information as being threatening and therefore painful. So those mechanical, temperature, and chemical sensors in our tissues might not be picking up any information that would indicate danger, but by the time the message gets to the brain and is interpreted by the brain, it has been ramped right up, so the person feels pain. This means that pain does not always equal tissue damage, and pain can be present even without any damage occurring. Now, as well as pain being divided into acute and chronic, there are 3 main different types of pain. The most common is what's called nociceptive pain. This is when there is actual or potential damage to tissues in the body, excluding the nerves. And this is the sort of pain you would experience if you sprained your ankle or if you have osteoarthritis. In some people with Parkinson's, some impairments like dystonia, dyskinesia, and rigidity, along with things like a flexed posture where the person's spine is stooped over, can also contribute to this type of pain. The second type of pain is neuropathic pain, and this is pain due to a problem with the somatosensory nervous system, which is the system involved in sensations, including touch and pressure and pain. In people with Parkinson's disease, problems with posture, again, can lead to neuropathic back pain, so things like sciatica, due to compression of nerves in the spine from the altered posture. The third type of pain is nociplastic pain, and this one's really complex. This is where pain is due to central pain mechanisms in the brain and nervous system, such that pain occurs despite there not being any actual or threatened tissue damage and no lesion of the nervous system. It is thought to happen because the way the nervous system processes pain signals gets mixed up or becomes overly sensitive, and there are changes in how the brain and spinal cord handle that sensory information coming into them. This type of pain is very variable in presentation, can be hard to localize, and fluctuates in intensity. And some people with Parkinson's can have nociplastic pain as part of the disease process due to changes in the nervous system. Now, I've presented these three types of pain as being separate things, but in reality, most people with chronic pain have a combination of these pain types. And once pain is chronic, then resulting changes to the nervous system mean that most people with chronic pain will experience some nociplastic pain. Now, that was looking at pain in general. So let's now focus on our attention on pain in people with Parkinson's disease. So if you're a person with Parkinson's and have problems with chronic pain, you aren't alone, because people with Parkinson's are twice as likely to have chronic pain as people the same age without Parkinson's, with some studies saying chronic pain can affect up to around 80% of people with Parkinson's, with the number of people affected increasing with disease severity. And why is that? Well, we know that Parkinson's affects many areas of the nervous system, including areas that we know are responsible for interpreting information as pain, and the areas responsible for sending the descending pain inhibition signals as well. So in people with Parkinson's, some of the key parts of the system that deal with pain are affected by the disease. So that means pain in people with Parkinson's can be directly attributable to the disease process itself. And this is what we call central neuropathic pain, which tends to be a tingling, burning, or shooting pain, and is estimated to affect about 10% of people with Parkinson's. Pain can also be due to structural or biomechanical abnormalities like arthritis or an injury. And as we saw previously, the nervous system can be sensitized, leading to chronic pain, where the relationship between the aggravating factors or the causes of the pain and the actual pain felt can become out of proportion due to that sensitization. And to add to this, the other impairments associated with Parkinson's can also exacerbate the pain, so things like rigidity and dystonia. Now, sometimes people talk about pain due to Parkinson's and pain unrelated to Parkinson's. But I think it's important to realise that all pain experienced by a person with Parkinson's is influenced by Parkinson's. Now, if you think back to the definitions of pain and chronic pain, you'll recall it talked about being an emotional experience. So that flags to us that there is more to pain than just biological mechanisms. We know that in all people, pain, and particularly chronic pain, is a biopsychosocial experience. So pain is a subjective experience with important social and psychological components, as well as the biological or sensory components. So socially, a person's experience of pain will be influenced by things like their cultural beliefs or their social support. Psychologically, things like their beliefs about the pain and their emotional response to the pain will influence their pain experience. So, for example, if a person is feeling anxious or stressed and they believe that they have done damage to their body that's getting worse, then their pain is likely to be felt as being worse than if they are feeling supported and happy and have a belief that pain doesn't always mean tissue damage. So pain is not just all about senses and tissue damage. Now, these are the common things that influence people's pain experience. So poor sleep, anxiety and depression can all exacerbate pain, as can what they call maladaptive pain beliefs. So things like, if I feel pain, it means I'm causing damage to my body. Then the level of emotional and psychological support that a person has can also influence their pain. And some of these things actually have a bidirectional relationship with pain. So, for example, sleeping poorly can exacerbate pain, and feeling pain while trying to sleep can lead to poor sleep. And this is similar for mental health issues where pain can contribute to poor mental health, but poor mental health, such as feeling anxious or depressed, can make pain feel worse. So what do? Parkinson's is complex and pain is complex. So if someone has Parkinson's and pain, what next? First of all, you should tell your doctor. Sometimes doctors can prescribe analgesic medications to help with the pain. Also, we know that having an optimal regime of Parkinson's medications can help to reduce pain because it helps to manage the impairments like rigidity, and also because pain sensitivity has been shown to be improved when people are on optimal doses of levodopa medication. So while in this talk I'm focusing on non-pharmacological interventions, please know that these are in the context of having good medical management of the Parkinson's. So it is not instead of medication, but as well as. So once a doctor is aware that the person with Parkinson's disease has problems with chronic pain, they can use a flow chart like this to guide what we call a biopsychosocial approach to managing the pain. So to start with, the doctor can include a pain assessment and look at whether the type of pain the person is experiencing is predominantly nociceptive, neuropathic, or nociplastic, and whether there are any medical treatments that can help. The doctor can then screen for potential other influences of pain, so things like poor sleep, anxiety, and depression, and can also optimize pharmacological management of these. Then the doctor can also refer to other members of the multidisciplinary team, like physiotherapists, exercise physiologists, psychologists, and so forth. And ideally, these people can work together to determine an individualized approach that will address the factors that are contributing to pain for that person. That could involve things like psychological strategies to help improve sleep, and in my opinion as a physio, should always involve exercise. And why do I say it should include exercise? Well, funnily enough, it's not because there's lots of evidence about exercise for pain management in people with Parkinson's, but there is quite a lot about it for the management of chronic pain more broadly. So drawing from that knowledge, we can sensibly apply what is known more broadly to people with Parkinson's. The second reason why I think it's important to include exercise here is because we unequivocally know that exercise is beneficial for all people and all people with Parkinson's. So everyone with Parkinson's should be exercising as part of the disease management, and that includes people with Parkinson's who have pain. So people with Parkinson's and pain need to be exercising for disease management. Then the pain aspect needs careful attention to ensure the exercise prescription is not only effective for disease management, but is hopefully helping with pain management, or at the very least, not exacerbating it. This slide shows the Parkinson's Foundation exercise recommendations. So they recommend aerobic exercise like walking at least 3 days per week, strength exercises 2 to 3 days per week, and then both balance, agility, and multitasking exercise, along with flexibility exercise at least 2 to 3 days per week, but preferably daily. Now, we know in the general population amongst people with chronic pain, aerobic resistance and flexibility exercise can be helpful for chronic pain management generally. So it's also likely to be helpful for people with Parkinson's and pain. Having said this though, please keep in mind that this is the ideal exercise regime. It's something to aim for and to discuss with an exercise professional like a physio or an exercise physiologist. But it is also something that people need to gradually build up to over time. Now, as I said, there's not a lot of evidence about exercise for pain management in people with Parkinson's. Studies have tended to use exercise programs that have been designed for other aspects of Parkinson's disease, like improving walking or balance. But often these studies measure quality of life, which means they measure the bodily discomfort aspect of quality of life, which is a subscale of a commonly used Parkinson's disease quality of life tool. So this is some unpublished data from my PhD student, Vanessa, and it shows a graph called a forest plot, which is a way of putting the results from lots of different studies together. And we can see in this graph lots of studies where half the participants did some form of exercise and the other half didn't, and they measured bodily discomfort. And there were lots of different types of exercise used in the studies, including aerobic, strength, and combinations of exercise types. But when we include all these exercise types together to look in a very general sense at the effect of exercise on pain, we can see that the studies are tending to have an effect on reducing pain. So that is shown by the boxes that are to the right-hand side of the line. And also, if we pull them all together, we get the diamond at the bottom, showing that following exercise, people with Parkinson's have a small reduction into the amount of bodily pain they experience. This is another graph, this time separating programs with less than 150 minutes of exercise per week at the top compared to ones with more than 150 minutes at the bottom. And the result shows that the programs with more than 150 minutes of exercise per week helped reduce bodily discomfort, whereas the ones with less than 150 minutes did not. Now, this doesn't mean that if you haven't been exercising, you should jump in and start on a program with more than 150 minutes per week. That's not what you should do because you need to do what's called pacing to build up over time in order to avoid pain exacerbations. And I'll talk more about that in a minute. This final graph shows the effect of aquatic exercise, so exercise in water on pain severity in people with Parkinson's. And interestingly, it is a small number of studies, all done by the same author, which does mean that the certainty of this evidence is low. Nonetheless, it is showing that water-based exercise can reduce pain. So while the strength of this evidence is low, I think if you have Parkinson's and pain and you enjoy exercising in the water, then that is a good thing to try. I'm not talking about swimming laps, though that's a good form of aerobic exercise. This is more things like walking around, stretching, and postural exercises in water. So the other type of exercise that has been a tiny bit of research done in people with Parkinson's is looking at Pilates, yoga, and postural or trunk exercises. And it's only a tiny bit that's been done, so we need more research. But preliminary evidence suggests it might be beneficial for people with Parkinson's and low back pain. We mentioned flexed or stooped posture earlier and how that can contribute to pain in people with Parkinson's and in particular lead to back pain. So these types of exercises that can help improve the movement of the spine and stretch the muscles around the spine seem to help with pain associated with the back. For the next few slides, I'm going to talk about some important points to consider with exercise for people with Parkinson's and chronic pain. First, it's important to get a good understanding of the activity levels that the person can tolerate without flaring up their pain, and then grade or gradually increase the amount of exercise from there. As part of this, it is important to monitor the person's response to exercise in terms of their pain, as well as things like fatigue and muscle soreness, so that monitoring can help with making adjustments to the graded exercise program. It is also important for people to realise that it is usually safe to move with chronic pain. So tolerable pain during exercise is okay and doesn't mean that it is doing you harm. But one thing to keep in mind is that you want to avoid this overactivity, underactivity cycle. And this is a cycle where people with chronic pain alternate between periods of excessive activity when their pain is low, which in turn flares up their pain and leads to prolonged rest or underactivity. And as you see in the picture, people can get caught in a boom-bust cycle, and this is best avoided. Much better to just ramp up very slowly over time. So what we want to aim for is a gradual increase in activity. So to achieve this, it's good to have a plan for managing flare-ups in pain. And a rule of thumb for this is if a person is doing a graded exercise program and experiences a flare-up of their pain, they should drop back their exercise to what they previously tolerated. And then when they are ready to progress again and have the then when they are ready to progress again, you can halve the previously attempted progression. Finally, alongside exercise, it helps to address any other factors that might be contributing to the person's pain, like poor sleep or mental health concerns. So we know that sleep problems are common in people with Parkinson's, especially those who have REM sleep behaviour disorder. And some of these problems can be tricky to manage. So if you're having problems with sleep, make sure you talk to your neurologist about it. There's no research that I've been able to find that's looked at whether improving sleep helps with pain in people with Parkinson's, but there is quite a bit showing that in people with chronic pain generally, improving sleep helps managing their pain. So it follows that people with Parkinson's and chronic pain may find their pain improves with treatment to help sleep. And there's lots of things that intervention might include to help people with sleep, but also just some simple things people can do to make it easier to move around in the bed can sometimes help people to sleep better and feel more comfortable. So things like satin sheets that are a bit slidier to help people turn over, or a bed rail to help you turn over and adjust your position at night, and so you're not staying in the one position for too long, and might help people to be more comfortable and to sleep better. Another type of treatment that might help people with Parkinson's and pain is psychological strategies. Again, there hasn't been studies done specific to Parkinson's, but from the general population, we know that people who use active coping strategies, like keeping active, going out, seeing their friends, being involved in activities, as well as doing graded exercise like we talked about before, these people report less pain than people who have more passive coping strategies like avoiding activities. Having also what gets called in the literature those maladaptive or unhelpful beliefs about pain are also associated with feeling worse pain. So from the research with chronic pain generally, I think it follows again that improving mental and emotional health is likely to help people with Parkinson's and pain to manage that pain. So addressing things like anxiety and depression, which are really common amongst people with Parkinson's, as well as learning active coping strategies and ways of thinking positively but realistically, might help some with pain management. Now, while there's no research specific to Parkinson's about cognitive behavioural therapy, general research suggests it would be a good thing to try. And interestingly, there was one small study of people with Parkinson's that trialled mindfulness. So mindfulness has been very topical in the media these days. But in this particular study, they actually found an increase in pain when people with Parkinson's used mindfulness, which I think might have been to people having an increased awareness of the sensations in their body. Now, I don't think that means we should avoid mindfulness. I think mindfulness can have plenty of benefits. It can be really helpful for managing mental health, but probably on its own, it won't help with pain. So for pain management, maybe it should be combined with other strategies too, like cognitive behavioural therapy, to help with the way people think about their pain. The last treatment I'll talk about is massage and acupuncture. In surveys, people with Parkinson's often mention using these to help manage their pain, but from a scientific perspective, there's been very little research and the research is quite poor quality. But I think with these, if you'd like to try them, then do. And if you find that they help you, then use them. So to finish up, I'd just like to recap the main take-home messages from this talk. So firstly, chronic pain is very common in people with Parkinson's, and if you experience this, then please let your doctor and any other health professionals you work with know. As Parkinson's affects parts of the nervous system involved in processing and modulating pain information, then any pain experienced by a person with Parkinson's will be influenced by their disease. Importantly, pain does not always equal tissue damage. Often in chronic pain, it is due to a sensitized nervous system. And pain has physical, psychological, and social factors that contribute to it. So to assess and treat pain optimally, we need to be considering all of these. Finally, while the knowledge about pain in people with Parkinson's is gradually increasing, there's still a long way to go, and we need more research to better understand it and to know how to best manage it. So I hope that information has been helpful, and we'll go back over to the hosts.
Thank you so much, Natalie. That it's such a complex, I think, thing, pain, but you've just explained it so clearly. Thank you. That was just brilliant. I think we've got quite a few questions in the chat, and we invite people to put their questions actually in the Q&A if possible. And Jane, I think, is going to read some of them out so that we can answer them.
Yeah, thank you, Natalie. I certainly learned a lot from that talk. So thank you for sharing all your expertise and experience. And we've got 215 participants joining us. So as you can expect, quite a few questions. We'll see how many we get through. Somebody has said that they have Parkinson's and they're interested to know, should they be having certain tests annually just to make sure that the aches and pains they're experiencing are related to Parkinson's, or could it be something else? What would your general advice be to that?
Yeah, so I mean, obviously I can't give any specific advice for any particular people related to these questions. People should always be talking to their health professionals that know them well. But generally speaking, we don't really recommend just routine like scans and tests to sort of investigate people's aches and pains. What is much better, I think, is a kind of, very holistic assessment, starting with your doctor and involving working with people from the multidisciplinary team as appropriate, related to what sorts of factors might be contributing to your pain. I think there's a temptation to try and look for what things might be happening in the body that might explain people's pain, or be able to point to a certain bit of arthritis or a certain problem with your back or something like that. But they found that oftentimes what they can see on these scans doesn't correlate very well with people's pains. And the more you look, the more you find, and the more problems you can actually bring up for yourself. So I think the doctors know what sorts of things to look for that raise alarm bells to suggest something really sinister might be happening, and then they would send you for a test. But I don't think just routinely it's required.
That's great. No, great advice. Thank you. Somebody from Queensland, actually, who also has Parkinson's, is explaining that they had some surgery on their back a number of years ago. And because of this, they can't go to sleep on their back. So they're tending to lie on their right side or their left side for the whole of the night. And that when they're waking up, they're getting a lot of pain around their hip bone. They wondered whether it might be related to sciatic nerve issue. And we actually had this question emailed through, and I just said it's probably worth just seeing your GP to answer that part of the question. But the part we'd like to ask you, Natalie, is if somebody's really struggling to turn over in bed, are there things that you can recommend to try and reduce that hip pain when they're waking up?
Yeah, so I think it's good to be able to, obviously people with Parkinson's often have trouble moving in bed in the nighttime, and being in one position for a long time can get very uncomfortable. There's things you can do to try and move around a bit more in bed. So things like satin sheets that are a bit slidier to help it to be more easy to turn in bed, or rails on the side of the bed to even just hold on to and adjust your position or to turn over, or sometimes what we call movement strategy training, to practice being able to turn over or roll over in bed, where you break that task down into steps and you consciously think through each of those steps to reposition in bed at night. If physiotherapists should be able to help you to sort of learn that kind of technique if that's something that you want to try. But yeah, repositioning a little bit through the night might be able to help with that comfort.
Yeah,
And it
the
might
other
be
thing,
just, oh, you go, Jane.
sorry, Michelle.
I was just going to say the other thing you might want to try is sometimes some small cushions or pillows between the legs, but also making sure that your mattress is not too hard or not too saggy. And sometimes people do get hospital beds that are electric if they have the funding to kind of help move as well.
Mm.
And the other thing that I was going to add, again, it's very multidisciplinary, isn't it? It is also worth asking your neurologist or geriatrician just to have a discussion whether there might be some symptoms. So when people's medications are wearing off overnight, they may get some more muscle stiffness, or some more bradykinesia, so slowness, again, making it hard to turn in bed. And sometimes just a slightly higher dose of something containing levodopa like Madapart or Sinemet in the evening can just help with that a little bit as well. So I think it's often this physical therapy as well as just considering some of those pharmacological aspects as well. So a few more questions, Natalie, coming in. Somebody said, I have a lot of left-sided facial neuralgia that feels like numbness following in dental injections. And their neurologist and GP said it is not associated with Parkinson's, but they're not so sure. Do you have any comments on that sort of pain around the face?
Yeah, it's difficult because, people with Parkinson's, they're people. They have all the same sorts of things happen to their body that can happen to people without Parkinson's. But I think it's helpful to realize that if you've got Parkinson's, then you're experiencing pain that's being interpreted by a nervous system that's affected by the Parkinson's disease. So I always find it difficult, this pain's Parkinson's related and this pain is not, is an interesting kind of conversation, because in my mind, kind of, if you have Parkinson's disease, then that the changes in the nervous system are going to influence the way that you interpret pain. In relation to what might be happening for this particular person, that sounds, particularly uncomfortable. I think, talking to your doctors about what sorts of treatments might be available, Parkinson's or not, to help settle this down, would be a good idea. But yeah, for yourself, bear in mind, if you've got Parkinson's, that's going to influence the way that your brain interprets pain, I believe.
Yeah, we've got an interesting sort of practical question here, asking about whether water bearing or hydro exercises, are they okay? Could it potentially help with pain in Parkinson's? And just asking for your thoughts around that, really.
Yeah, so there is a little bit of evidence that doing exercise in warm water is beneficial for pain in people with Parkinson's disease. It's what we'd call low certainty evidence, which doesn't mean that that it's not effective. It just means we need to do more research in that area to understand it better. But I think if you enjoy moving around in the water and you find that type of exercise is comfortable and helps you to manage your pain, then I think it's a great thing to be doing.
Thank you, Natalie. We're getting a lot of positive comments about how wonderful your talk was. We've got some positive feedback from Sue and from David.
Thank you.
And others saying, can they access your slides after the talk? And I think I can answer that one, just to say that all of the webinars you can access. You just need to look up the Tasmania Parkinson's Project website, And then there's a little tab where you can just find webinars. There is usually a little lag, so a few days to upload the webinars, but they will be there. So please come back and have a look at those. But lots and lots of positive comments here. Are you all right for a few more questions, Natalie?
Yep, that's fine.
KTAS, is there any emerging research on massage and pain that would support the issues? Because so many NDIA participants are now experiencing, and it's no longer available under the plans.
Yeah.
So thoughts around massage and
Yeah, so that's another one where there's very little research being done actually, and the little bit that has been done was very poor quality research, unfortunately. So that's one where I think the difficulty in relation to the NDIA perhaps is that we don't have kind of good, robust research around whether that sort of soft tissue massage is helpful for pain. I do think that often a lot of people report that it is really helpful for them. And I've spoken to a lot of people with Parkinson's disease and also seen some, published surveys that were done with people with Parkinson's that ask them about what helps with their pain management. And people do talk about things like massage as being useful. So I think if you find it helpful and you can access it, then that's a great thing to use. So that would be good. And yeah, it's unfortunate it's not available on NDIS packages, but maybe if there is more research that comes out, that might change in the future perhaps. But if you can access it and pay for it or persuade a loved one to give you a massage, if they're good, sometimes that can help too. Yeah.
Sounds good. And that's a nice segue. We've had a few questions about research and saying that people would like to take part in research, but not yet seen the links. Just to confirm that the research we mentioned today, that's the TAS test, the computer test, the blood tests, and the questionnaire on walking and cognition. They are already sent out, or they will be sent out again. So just have a look. If you log into the website and look under your own profile, there should be a little tab that you can click to access that. We will be sending out some more reminders as well. All right, a few more questions. Can you recommend suitable mindfulness programs for people with Parkinson's?
I'm not. Michelle might know. I'm not aware of any specific for people with Parkinson's disease, but there's a number of different, good apps and things that you can find, to have on your phone or your device to help you take you through different mindfulness types of, scenarios and meditation practices and things like that. And so there's a variety of ones out there. I think there's one that Headspace puts out, and there's a couple of other ones.
Smiling Mind is a good one.
Smiling Mind, yes.
Yeah.
So that one, that's quite good. So it's not specific to Parkinson's, but I don't think it needs to be.
That's really useful, Natalie. We've been asked a lot about mindfulness, haven't we, Michelle? I think we should think about doing a webinar specifically on mindfulness.
Yes, good idea.
So we're open to all your ideas, but we've noticed that's a common question. Okay, Natalie, I've got a question from Elle who says, thank you so much for the webinar. I already do a lot of exercise, but I have terrible pain in my neck, shoulder, and the top of my arm, the deltoid muscle. Do you have any suggestions for this? And should I look at a rehab type exercise? It does seem to be on the more Parkinsonian side, so it might be related.
Yeah, and we do know that Parkinson's symptoms like rigidity are related to pain in people with Parkinson's. So people that experience more rigidity experience more pain. You could look at trying a few different strategies. So we talked about gentle movement in warm water before, also things like Pilates or sort of exercises that are aimed at sort of flexibility and improving trunk posture and that sort of thing that have been found helpful for back pain, they may well also be useful for this sort of pain that you're describing as well. You could also try some massage and heat therapies and things like that to see if it helps to improve that. But I think one of the keys is gentle movement, not being afraid to keep on moving. It's when we stop and we don't move our bodies very much that we tend to get even more problems with pain and stiffness. So keeping on moving gently and exploring some of these different strategies we've talked about today and seeing what might help with your pain and your situation.
Yeah, great answer. Somebody is asking actually about rest, and Doug says, my back pain actually improves when I lie down for 30 minutes. Is there any reason why lying down and resting for a while is contraindicated?
Yeah, I think lying down for half an hour or so, that's fine. It's the problem is, years ago, some of the advice for people with back pain used to be prolonged bed rest, and we now know that that is a very problematic thing to do if you have back pain, that it's actually good to keep moving. But there's nothing wrong with lying down for half an hour or so if you find that helps take the pressure off and it just helps you to relax and helps to ease your pain. As long as it's all about balance. It's about balancing rest and balancing activity and exercise so that you're moving your body, you're helping your body to be strong and fit, but you're also giving it the rest that it needs. So getting that balance between the two.
And we've got a question here about atypical Parkinsonism. So we've got somebody saying, what is the experience of pain with progressive supranuclear palsy, also known as PSP? And do you recommend exercise for PSP? And just to remind everyone on the webinar that everybody's welcome to the Tasmanian Parkinson's Project. So it's not just for people with Parkinson's or their families and loved ones. Atypical Parkinsonism, which includes some of these rarer conditions. You might have heard of PSP, MSA, something called CBS. Much of what we're talking about here is usually relevant too. So thank you if you have one of those conditions for joining us. But over to you, Natalie. What do you think about progressive supranuclear palsy and exercise?
Yeah, so because PSP is less common than Parkinson's, I think that we don't have as much research done with people with PSP as what we do with Parkinson's. But what we do know from research with people with Parkinson's and from research with people more broadly is that exercise generally is very good for everybody. And so I think whether you've got atypical Parkinson's or idiopathic Parkinson's or whatever, I think exercise is really important to be doing to help to optimize our health and optimize our movements. With something complex like PSP, it probably would be a really good idea to find a physio that has some expertise in neurological disorders to help guide your exercise and make sure your exercise is appropriate and safe and meets your goals. But yeah, it's a good thing to be doing.
And a question here that I'm often asked in clinic actually is about acupuncture. Is there any evidence that acupuncture is helpful for pain in Parkinson's, or needling by physio? And what's the difference between needling and acupuncture?
Yeah, so there's not evidence. There's only been a couple of really small, not very good quality studies that have looked at acupuncture for pain management in people with Parkinson's disease. It's one of those things where I think if it appeals to you and you want to try it, then try it. And if you find it helpful, then use it. And if you don't, then don't. In terms of difference between acupuncture and dry needling, I think it's about, I'm not 100% sure what the difference is there. Maybe it's about the particular device that they're using on the skin. but they're very
And
similar.
maybe the points as well. I think there's particular acupressure points, whereas maybe dry needling, again, not my area, but I think there might be different points that you put it in the muscle for dry needling.
But it's worth a try if you're looking for things that might help. Some people certainly say that they found they get good relief from it.
Yeah, somebody's asked a question about, can you administer painkilling medications with Parkinson's medications? I'm happy to take that one if you like, Natalie.
Yeah, I might defer that one to you, Jane.
The doctor here. Yes, you absolutely can. You know, we're always looking for potential medication interactions, drug interactions between Parkinson's medications and any other medication. I think generally, you know, things like paracetamol, ibuprofen, they're normally absolutely fine to be taken with Parkinson's medications. Some of the stronger medications like tramadol or morphine-based medications, oxycodone and so on, my experience is that in anyone, they can cause quite a bit of sedation, constipation. And as people with Parkinson's are a bit more prone to those side effects, I tend to be quite cautious of those stronger ones. So that's not to say we can never give them, but we would tend to try some physical therapies and other ways of managing the pain before just reaching for those tablets. So I hope that answers your question. It's not an absolute contraindication to take painkillers, but we're just cautious not to cause more problems than we're solving. We're getting a few questions about the MOOC. You might remember the MOOC, the massive open online course, which was opened in February and then closed after a few months so that we can analyse feedback. As Michelle mentioned, it's going to reopen again at the end of October. You'll be hearing lots more about that. So if you've already done it, we hope you'll come back. But if you haven't, definitely come back. There's lots of interesting information in there. Somebody has mentioned here, Natalie, about sometimes at the beginning of Parkinson's, people can present with shoulder pain that looks a bit like a frozen shoulder, and they're actually told it's a frozen shoulder and it's not recognised it could be part of Parkinson's. I just wondered if you could comment on sort of the difference between a frozen shoulder and some of the signs that we're seeing with Parkinson's. But this particular person's also said, does that shoulder pain tend to persist throughout Parkinson's? So there's two questions there.
Yeah. Yeah. And I think frozen shoulder is a little bit more common in people with Parkinson's than in the general population. I think that, you know, perhaps some of the other symptoms of Parkinson's can predispose people a little bit to things like that, and to back pain as well, and more common in people with Parkinson's. In terms of whether or not the pain persists throughout the disease course, not necessarily. It will depend on a number of factors, and everybody's different. But there are things that you can, you know, if you do things to help address the problem that you're having with your shoulder, and look at ways that you might be able to do, you know, some exercises or different, sorry, I just aware I think somebody might be about to open the door. Look at different things that you can do to help manage that shoulder movement, and to, you know, optimize your flexibility and your strength around your shoulder. I don't think that it necessarily means that your shoulder is going to stay painful for the whole course, even if shoulder pain was one of your first symptoms. Again, I would talk to a physio that understands about Parkinson's disease for guidance on that.
So that's a really lovely positive note to end on. I think that things can definitely get better. And I think often those symptoms and signs that people present with before they're diagnosed, before they've accessed the correct treatment, they really can get better, and people can live really well with Parkinson's. Michelle, I'm aware that it's 2 o'clock.
2 o'clock.
On the hour.
Yes.
We need to wrap up. I'll let you close this wonderful webinar, but it's just been wonderful to see over 200 people today joining us. And I would personally like to thank Natalie for sharing her expertise and experience with us. Over to you.
No, thank you. And I think it just shows how important the multidisciplinary team is as well in treating pain and all parts of Parkinson's. And yeah, thank you, Natalie. You did such a clear presentation and your answers were super helpful as well. So really appreciate your time. And thank you, everybody, for joining us. And we do have another one coming up very shortly on vision, I think it is, Jane.
Yeah, we're trying to do a monthly webinar, so please come and join us. And if you've got ideas for webinar subjects that we're not covering, please just drop us a line via the website. We're really open to people giving us ideas, or if you want to speak on a webinar, even better, let us know. But yes, I think the next one is vision. I'll have to double check that.
Yeah, great. All right, thank you so much, everybody.
Thank you. Bye.
Close it down.
Thank you.